Thank you for this opportunity to discuss our 2021 East Multi-Center Trial entitled Social Determinants of Acute Abdomen Outcomes, sponsored by the Emergency General Surgery Committee, led by Dr. Rondi Gelbard of the University of Alabama, and I'm Heena Santry, a member of that committee. All of us who provide care to EGS patients are familiar with these two scenarios. A patient with a strangulated hernia with no medical care and no management of serious comorbidities for 2 decades, and an active 2-pack per day smoker who has no social network to help during the illness or the recovery. Or a patient who knows he has Crohn's but lost his insurance and could no longer afford treatment. His disease progressed and he lost 30 pounds. Both of these patients with acute abdomen are among a large cohort of patients who experience many adverse outcomes, including long lengths of stay, often more than 14 days, a 1/3 or higher rate of major complication, and for the 85 or 90% of patients who survive to discharge, a greater than 15% readmission rate. There are a number of social determinants of health, such as those listed here, that have been shown to influence adverse outcomes for a number of disease processes. These same determinants are more prevalent amongst EGS patients, according to large database reviews. However, the degree to which such determinants are actually present amongst acute abdomen patient populations and how they affect outcomes is poorly understood. Therefore, this trial aims to evaluate the association of social determinants of health and 30 and 90-day outcomes for acute abdomen, as listed here. A secondary aim is to evaluate the association between these same social determinants of health and illness severity at the time of presentation, as can be measured by objective criteria of sepsis or systemic inflammatory response syndrome, as well as clear documentation of a contaminated case in the operating room record. We will be collecting data from our participating sites using a REDCap database where information is de-identified at the site and patient level. Patients in the cohort will have been treated for acute abdomen, which includes a laparotomy within 12 hours of presentation to be consistent with other national databases for the dates shown here. Our exclusion criteria will include prisoners, those without an address listed, and those whose presentation actually reflects a complication from a recent EGS admission in 90 days. Our key predictor variables will be local socioeconomic factors as determined by 3 or 5-digit zip code using the Area Deprivation Index, which is a composite score of various factors related to poverty and other local issues such as food insecurity and housing insecurity. Social support will be determined by case management and social work records. Employment, education history, and source of routine care will be recorded as noted in the electronic medical record. Our outcomes are listed here and will include index hospitalizations such as severity of illness, length of stay, and discharge disposition, as well as complications during hospitalization at 30 and 90 days, and readmissions at 30 and 90 days. We've included 90 days because given the long lengths of stay that many acute abdomen patients experience, especially those with adverse social determinants of health that may delay discharge, we feel that the typical 30-day follow-up period that is used for elective surgery may not be applicable to this patient population. The primary research site is where I am located at the Ohio State Wexner Medical Center. Our site lead will be my partner, Dr. Alex Helkin, and our project coordinator is Dr. Holly Baselice. Her contact information is listed here and is at the bottom of all of the slides. Our progress so far includes that our REDCap database is ready for data entry, and our data dictionary has been finalized and shared on the EAST website. Our prior IRB, which did include identifier variables, has been updated to allow for a de-identified multi-site project. We've had discussions with interested parties and have made the decision that because everyone does not have a single IRB process, we will have individual institutional IRBs to participate and have a data sharing agreement. Our targeted timeline is listed here and allows for participation and sharing of final data at the EAST 2023 Scientific Assembly. These are the interested sites so far, and we are excited to have more interested parties contact us between now and the middle of next month so that we can start collecting data in earnest in March. Thank you.